3, where it's like the circle that says life-threatening. Go with me? Okay. So when we talk about these, they're emergencies because something has happened either with the cancer or the cancer treatment, right? So chemo or radiation or the cancer that has put the patient in a life-threatening position. And if we do not respond quickly, there is very high mortality associated with this. So what we're going to think about is identifying it early. So thinking about the patients who are at risk for developing those complications, and then trying to identify signs and symptoms early, because if we let these conditions progress too far, it may be irreversible. All right, so go to the next slide. So there's kind of some categories. The first ones we're going to talk about are obstructive, where something happens to obstruct an organ or a blood vessel. So the next slide, I really wish this would work, but we'll make it work. Okay, superior vena cava syndrome. Have y'all heard of this? Probably not, this is probably new one. Where is the vena cava? Everyone's like, here, right here. Yeah, so the superior vena cava, we're talking about the vena cava that's going to drain blood from the upper extremity and the head. Okay, so it's not the inferior vena cava. We're not talking subthoracic, right? We're talking about the upper vena cava. This is what happens in superior vena cava syndrome is something, it's often a tumor, grows to the point where it puts pressure on the vena cava. And if you put pressure on the vena cava, blood can't flow through it like it needs to be. So as a result, we have impaired venous return to the heart. We have a buildup of fluid in that venous system. We see this is, again, these are all pretty rare. But often when we think of who's at risk for this, it's patients who have tumors developing in their thoracic area. So lung cancer can do this, lymphomas can do this, and then any sort of metastatic tumor that's landed in the lungs often. But it's these tumors that they grow and they grow and they grow, and they start to push on the vena cava. So again, lung cancer is the big kahuna on that one. And the way we would figure it out would be assessment. These symptoms develop rapidly for patients at times, but we could, on a chest x-ray, actually see that tumor. They might do a CT scan. They could do a venography with contrast where they actually look at the blood flow. But often it can be symptoms and chest x-ray. We can pretty quickly figure out what's going on. Let's go to the next slide. So what does this look like? Okay, we have an obstruction of blood flow in the upper extremity and the head. So we're going to see those manifestations. We're going to affect the neurosystem. We haven't talked about intracranial pressure and stuff yet, but if we can't drain blood out of the head, it's going to build up pressure. And because the vena cava is obstructed, you can't drain the blood as well. So they'll have headaches. If the pressure builds up enough, they can have seizures from this. We're going to see lots of respiratory symptoms, and these aren't necessarily because of the lung cancer, but it can be associated with it. But chest pain, cough, dyspnea, shortness of breath. If we think about it, if a tumor has grown large enough to obstruct and push on the vena cava, it's also compressing lung tissue. It's also compressing other structures. So they'll have some of that heaviness in their chest. It can actually displace the trachea slightly, and so they can feel that choking sensation as well. And then when we have that poor return, it's from the upper extremities, the chest, the neck. So they're going to see a buildup of fluid. So the veins of the head, the neck, and the upper arm, the chest will be very dilated. And then they can also, if it stays like that, get edema. So it's kind of like what we've learned about with right heart failure, right, where we see edema. But this is an obstruction in the superior vena cava. So that edema is just in the upper trunk in the face. So to care for it, again, we want to find patients. Think about who's at risk. Any patient who's having difficulty breathing or feeling like they're choking, there's an anxiety component to that, right? Because they feel like they're suffocating or they can't breathe. So we do need to manage anxiety for them. We're going to apply oxygen. Sometimes that can help with anxiety, but also there's a risk with that tumor that maybe there's some hypoxia with this. Steroids work really well to kind of, if there's any inflammation, sometimes, and the steroids can also help with pain and other reasons. We use steroids a lot in cancer care at times. Diuretics will help offload some of that volume. And then anticoagulants, again, if blood's not moving, there's a risk for clots. Now, none of that's fixing the problem. All of those is just sort of managing the symptoms associated with it. What really has to happen is the tumor itself has to be reduced. So we either surgically go in and debulk or remove the tumor. They might need chemo or radiation to shrink the tumor depending on where it's at. Some other things we want, if they're having difficulty breathing, the things we've learned about. So semi-Fowler's, we're gonna monitor perfusion and fluids. We're gonna do limb precautions on those upper extremities because as we talked about, never mind, that was the other box. I get them confused. Okay, but if you can't do good venous return, the lymphatic system runs parallel to the venous system, so you're also gonna have lymphatic obstructions. So you're gonna see where the fluid and the edema is building up, and so we don't want to do venipuncture, blood pressure. That's just gonna worsen any of that congestion in the extremities. And then why would we want patients to not strain? So straining increases intra-abdominal and intrathoracic pressure. If we increase the pressure in the chest, it's gonna further compress the vena cava. It can make some of those symptoms worse. Or if they developed a blood clot in that vein because of that tumor obstructing it, it could be enough to dislodge it. So we do want them to avoid straining. All right. So let's go to the next one. Spinal cord compression. Looks like spinal cord injury, which I know y'all haven't had yet, but the reason is because of a tumor. And so we see that in this situation, it's where there's a tumor in a vertebrae itself that starts to grow to the point now it's compressing the spinal cord itself. If the spinal cord has any pressure on it, it does not conduct electrical signal well. And so pretty much when we talk spinal cord injury, wherever that lesion is, wherever that injury is, in this situation, wherever that tumor is, everything below that does not get the nervous signal that it needs. It doesn't function well. So if they were to have a thoracic tumor, that's more in like the thoracic spine, you're gonna see issues with breathing and lower extremity movement and a lot of, anything from like the torso down, right? If it's more of a lumbar or a sacral tumor, they might just have issues with voiding and defecation and their use of their legs. So it really depends symptom-wise on where the tumor is, but keeping in mind it's wherever it is below is where they lose the sensation and the motor control as well. This is a neurologic emergency because if they can't, not only is the spinal cord being compressed, but the arteries and the veins that feed the spinal cord are also being compressed. So we get infarcted spinal cord tissue as well. So the pressure needs to be removed quickly because if the tumor is allowed to continue to progress to full obstruction, then there's no going back from that. We typically see bone cancer. It doesn't necessarily come from originating in the bone. It typically is other cancers that metastasize. So prostate cancer is notorious for loving to metastasize to the bone. So there's certain types of cancer. So it's going to be more metastatic. Breast cancer loves to metastasize, lung cancer, and prostate. There's other ones as well. So again, a lot of times they're gonna maybe do a CT scan, we're gonna do an assessment, but you have a patient who all of a sudden is having paralysis below a certain level, and we know that they've got cancer, they have bone cancer, we're pretty quickly gonna put 2 and 2 together to realize that this is a spinal cord compression. And I kind of mentioned this, but it says neurologic function prior to treatment is the best indicator. Again, if you've lost function, it's harder to get it back. If we're early stages where there's just some weakness developing, if we can decompress, we can likely restore. But if the spinal cord infarcts and dies, that's it. Okay, so next slide, manifestations of management. This is gonna look like wherever the lesion is and below, there's gonna be impairment of motor and sensory functions. Early stages, they might have paresthesia, so that numbness and tingling. It ultimately can progress to paralysis. This is a tumor on the spine, and you have nerves, right? So that compression will be incredibly painful. So these are patients who will report very severe back pain, and even on palpation, that tumor is gonna be causing pain. So where you palpate it, they'll have a lot of tenderness. And then if it's at a level above bladder and bowel function, they could lose that as well. So we're gonna treat this like we would spinal cord injury, right? Probably need to go and surgically decompress that tumor, but from a nursing management perspective, we're gonna limit it. I mean, if they're a fall risk because of weakness or paresthesias, right? Definitely gonna encourage activity limitations. Pain management because of that really bad pain in the vertebral space. Safety is a big thing, right? So we definitely have to protect our patients from injury, especially because as it progresses, they'll lose more function. So let's just say right now they're kind of weak, but then all of a sudden it gets worse and now they're paralyzed. And it can happen quick enough that they may not realize the loss of the functions progressing. So we need to make sure we're always kind of monitoring them, helping them to move safely so that they don't develop any kind of problems from that. We fixed it. I figured it was something super simple. Thorough assessments because of this changes. So they might need immediate radiation. They might go straight to surgery and decompress. Well, they may give steroids, again, to help reduce any inflammation associated with this. And then possibly rehab, but again, this is sort of after the decompression's occurred, right? Rehab while the disease is evolving may not be the best plan. So then we have metabolic emergencies, and these are where there's hormone imbalances that are generated from tumors. We talked about there's some cancers that are very hormone driven, or that the cancer treatment screws up something metabolically. So we'll talk about what those look like next. SIADH, have y'all learned about this yet? Yeah, right, I told you some of these, yay. What's happening here? Well, we remember SIADH, by the way I keep it straight is SIADH, there's too many letters, so you have too much ADH. DI, which is the opposite, the first two letters of diuresis is DI, so DI, you diurese. SIADH, you got too much ADH, so you retain fluid. Don't know if anybody's ever told you that, but that's what I do in my head. SIADH, so this is gonna be a lot of times associated with brain tumors, something that is affecting the pituitary. It's causing an excess release of ADH. ADH, as we remember, goes to the kidney. It works in that collecting duct and encourages water reabsorption only. It does not mess with sodium or electrolytes. It's only going to mess with water. So this is where we're not in a state of dehydration. We don't need the extra water, but because of that tumor affecting the pituitary, it continues to release ADH. So it can be with brain tumors, lung cancer is, we talked about it, right? It's got lots of problems, it's high mortality, high occurrence. Some lung cancers like to create their own ADH. They just do. They're nasty little buggers. So most of the time, if it's not from the brain, it's because it's a lung cancer and lung is making its own ADH. Those tumors just get all crazy. Or they're messing with the pituitary. Can also come from certain chemotherapy agents. It can cause issues as well. But what's going to happen, you're going to reabsorb water, lots and lots and lots and lots of water. So they're going to dilute out their serum sodium. They're going to dilute their blood, so their serum osmolality is low. They're going to have very high urine osmolality because they're not putting water into the urine. It's just going to be a lot of electrolytes and solutes. They're going to have very, very concentrated urine. But the kidneys are functioning fine. Often when we think decreased urine output, we're worried about kidneys. Kidneys can do the work. They're just doing what the ADH is telling them to do. No, you don't have to know those numbers. So what does this look like? Well, it's going to look like a patient who's overloaded and hyponatremic. So lots and lots of neuro issues. The brain is very sensitive to sodium. The brain's actually going to take on that fluid and you'll have cerebral edema issues. So lots of issues with level of consciousness and seizures. Weaknesses can occur. Now y'all remember, with nausea, vomiting, I'm like, yay, something's unhappy. So yes, it can happen with SIADH, but with a lot of things as well. They're gonna have weight gain. These individuals tend to not get as edematous as people who have other types of venous overloads. Don't know why, they just don't. But again, the oliguria is because they're not able to put the fluid into the urine. So we have to ideally find the cause and treat it. We're focusing and prioritizing neuro and respiratory because they can get pulmonary edema with this. So respiratory assessments, we're gonna monitor their fluid status and do weights. They need to be on seizure precautions, and why? It's because they have hyponatremia, which leads to seizures, and they can develop cerebral edema, which can cause seizures, and they've got both of those happening concurrently. So lots of high risk for neuro impairment and seizures. They don't need any extra fluid, so we will restrict fluids, but we're gonna encourage salt, right? Because their sodium's low. So we're gonna want them to take on. Very rarely in my career have I given sodium, but I remember I had a heart failure patient who was hyponatremic, and I literally gave him salt tablets. Like, this goes against everything I believe as a cardiac nurse, but take salt. It felt wrong, but he needed it because he was very altered. So again, these are patients where we're giving them salt until we can get that condition corrected. If it gets bad enough, they may need to go to ICU and get IV hypertonic saline. We can only do that in the IV, or only in ICU, and diuretics. So we want to give the sodium and we want to get the fluid off. So if it's very, very severe, they might have to go to the ICU. And there's new drugs all the time, but this is one that they think can help with removing the water. Instead of diuresis is water and solutes, this can just kind of dilute or just diurese that water. How we doing on that? Yeah? Hypercalcemia. Y'all learned about calcium, right? Fluid electrolytes. Feel like it's been a hot minute? Yeah? So we'll do fluid and electrolytes. We have an online module. Did we? Not yet. It's coming, I promise. Okay. The big thing I like to think about is, so calcium we need for a lot of different functions. It has a metabolic function, lots of benefits. But I kind of think about when you have normal calcium, it's like the parents are at home, the family's working well. When you have hypocalcemia, which is not what we're talking about. Hypocalcemia, it's like when the parents go away and the kids are having a party, right? Everything's hyperactive and wound up, and you've got tachycardia and increased reflexes and everything's agitated. Hypercalcemia, it's like when the really strict, no fun aunt and uncle are in town and nobody's having fun, right? Everything's depressed. You're gonna have weakness, you're gonna have bradycardic symptoms, you're gonna have decreased deep tendon reflexes because everything's getting suppressed in hypercalcemia. So this is when we have elevated calcium, and it's because related to either the cancers or the cancer treatment, calcium is being leached out of the bone. So we can see this with a lot of different cancers: breast, lung, kidney, myeloma, bone mets. If you have mets, that metastases that land in the bone. But what happens is the tumor cells are releasing messages that really increase osteoclast activity. And osteoclasts are the cells that break down bone. They rev up their activity. So the bone is being broken down at a really rapid rate, and that calcium and that phosphorus is being dumped into the bloodstream. And we see this hypercalcemia affect the patient. Some chemos, so tamoxifen is an adjunct for breast cancer. It can cause it as well. But again, it's you've got cancers causing bone breakdown. That's so the pictures show it, by the way, like it's mostly bone issues. It's not really as much because the parathyroid hormone, right? When we regulate calcium, it's breaking down bone, reabsorbing from the gut or the kidney. With hypercalcemia and cancer, it's mostly the bone side of it is what's is contributing to that. So it's gonna look like hypercalcemia. So again, that fatigue, that depression, a lot of really suppressed, apparently they're so fatigued, I wrote it twice, very fatigued, but they are. It can progress to seizures as well. They'll have bone pain because their bones are really being broken down at a pretty rapid rate. They can have that calcium deposit in tissues, so they might have different calcifications developing that can be painful. They'll have dysrhythmias, they'll tend to have more heart block, more bradycardic, more slowing of the cardiac function. They'll have constipation and can progress to an ileus because the GI tract, the smooth muscles are suppressed and they're not moving actively as well. And that much calcium can really bog down the kidneys. So that calcium can bind up together in the urine and cause kidney stones. We can see again it deposit in the tissues, and it can actually lead to kidney damage if it keeps progressing. So we gotta figure out the cause and reverse it. Have y'all seen the theme? Find the problem, fix it, and in the meantime, symptom manage is kind of what we do. So try to stop the bone reabsorption. Bisphosphonates are good meds to kind of promote osteoblast activity, to try to build bone. It's more of a trying to stop it from getting worse. It's not gonna necessarily build bone, but it's gonna try to balance it out. So we're not seeing more bone loss than bone building. We want them to be hydrated. So these are patients we don't want the calcium in the urine to be able to clump up to make stones. So we're gonna hydrate the patient to try to dilute the urine. We want them moving because weight on bones promotes osteoblast as well. So using the bones encourages the body to keep the bones mineralized. Calcium is bound in the blood to albumin. So we do need to make sure what's their protein status. We want them to be eating good protein levels. And again, try to get that tumor treated because until the tumor is addressed, this is just gonna keep happening. All right, this is the ugly bugger. I mean, these are all bad, but tumor lysis syndrome just killed my kidney now. I mean, this is really a problem. And for some reason, NCLEX and ATI love tumor lysis syndrome. Just love it. This is where it often is going to come more after like chemo or radiation. It's not from the cancer itself. But when we're doing chemo and radiation, what are we doing? We're destroying tumor cells. We're trying to break them down. Well, so now you have all these cells that are being destroyed and they're breaking open and they're pouring their contents into the blood. And if it's happening really rapidly, you have this mass deposit of all of these intracellular contents in the bloodstream. So the tumor's lysing, yay, we're dealing with the tumor, but all that stuff has somewhere to go, and where it goes is the kidney. And it ends up getting stuck in the nephrons and destroying the nephrons of the kidney. So we see that the patient will go into acute kidney injury. So they start to not be able to put uric acid into the urine, so they build up uric acid. They get potassium imbalances, so hyperkalemia, hyperphosphatemia, lots and lots of electrolyte imbalances. But essentially, because the tumor is being destroyed, it damages nephrons and the kidney goes into failure. So myeloma and lung love to be problematic, so does, well, all of them. But have you seen lung on basically every one of these? So what does this look like? Well, you're gonna see issues with kidney disease, right? So this acute kidney injury, you're gonna see the buildup of uric acid in the blood, so uricemia. This is where they might get itching skin from the uric acid. If it can't get out, it deposits in the skin, they get itchy. Hyperkalemia, they're gonna have weakness, dysrhythmias. The hyperphosphatemia just makes it worse. This could also be a cause of, what was I saying? No, I was wrong. Okay, anyways, it makes it worse, right? The kidneys get bogged down with trying to get all this extra phosphate out. So it's this cyclical process. But then we're gonna talk about it more with renal in the coming weeks. But y'all remember, calcium and phosphorus have an inverse relationship. And as we retain phosphorus, we end up having hypocalcemia. So this is where we're gonna have the tetany, the increased deep tendon reflexes, the cramping. But basically, this looks like acute kidney injury. And it's rapid, like the kidneys shut down. So we wanna, again, find those patients who are at risk and detect it early. They may have to go on emergency dialysis. Hopefully this could be a reversible condition. We would hope they don't go to chronic kidney failure. Acute kidney injury can possibly reverse if we can clean the blood, get them on dialysis, hopefully allow the kidney to heal instead of taking more damage from more of these contents, more of these electrolyte issues. And then we've got to balance everything. So uric acid, allopurinol can help decrease uric acid in the blood. We might give them fluids to try to dilute the uric acid in the blood. They might get acid-base imbalances that we have to treat, and then things that we've already learned about the electrolytes. So we're going to manage hyperkalemia, so decrease potassium in the diet. Y'all remember insulin and glucose? Have they talked insulin and glucose? So insulin brings glucose into the cell, but also brings potassium into the cell. So if you give patients an AMP D50 and some insulin, it helps to shift potassium into the cells. It's a temporary fix, but hopefully it brings the potassium down low enough that they don't go into cardiac arrest. K-exolate is a lovely laxative that pulls potassium into the gut. You can use that if there's a healthy GI system. We'll give calcium supplements and phosphate binding agents to manage those electrolyte imbalances. And then again, the allopurinol is important for them to take because the uric acid issues are some of the most challenging symptoms for these patients. They get itchy, they don't feel good. They can develop gout where they get uric acid in their joints, so they need to take their allopurinol. All right, last couple here. Cardiac tamponade. This is not good. This is where there is a buildup of fluid around the heart, so in the actual pericardial sac. The sac doesn't stretch, it's pretty rigid, and so if there's a pretty rigid sac that fills up with fluid and it can't stretch, it pushes in on the heart. And if it's pushing in on the heart can't fill with blood, and if the heart can't fill with blood, it can't move blood forward. So this is patients who it's either there's a tumor that obstructs the pericardium, so it can't balance its fluid, or often it's for pericarditis from chest radiation, so for lung tumors or lymphomas or things in the chest. It can happen really rapidly. Of all of the conditions, this one is the one that can happen the most quickly. So they're going to have crushing chest pain. It's right behind the sternum often, or a heavy feeling in their chest. If they lean forward, it feels better. It kind of takes some of the pressure off of the pericardium. Lots and lots of cardiovascular symptoms. You're going to have muffled heart sounds. That fluid is going to decrease the ability of the heart sounds to be heard. They'll be tachycardic because the heart's in stress. The veins, so if you compress the heart and blood can't get in, like we've already talked about with kind of going to look heart failure-ish, right, with very dilated veins. So JVD, hypotension, because they can't move blood forward. They can get a lot of fluid overload in the lungs as well because they can't drain into the left ventricle either. The brain's not going to get perfused well, so we'll see those neuro issues. It can put so much pressure in the chest that they actually have difficulty swallowing as well. And they might be diaphoretic. The body's going into a stress response there. So this is, again, these are all emergencies. This is one we got to act quickly, because if we can't get blood moving efficiently, the patient will die. So we want to do good assessments, have them sitting up, maybe leaning forward if it relieves some of that pressure, put them on oxygen, because they will be needing the extra oxygen. And then often they'll put them on steroids to try to release any of that inflammation, try to get fluid off if they can, because they don't want to overload the system. But they got to go to surgery, right? This is a really quick, we can't wait and kind of adjust. Often they're going to go straight to surgery. They're going to cut open the pericardial sac to relieve the pressure. And then they might need a chest tube over time, or they might need to keep a window. Some patients, especially if they've had radiation to the chest, the pericardium can actually become sclerosed and scarred. So for them, they're just going to cut open that pericardium and leave it open, because otherwise it's just going to keep restricting the heart. But that's a decision they make in surgery. But for this one, we symptom manage until we can rush them to the OR. So that is the quick